for 36 years. I'm speaking on behalf of my other partners, of which there are 4, plus a number of fellows. And I've invited 2 people that we work with very closely. Dane Johnson is a urologist here at Washington University who works with our department. And Marisa is a genetics counselor who also works in our department. She hasn't since March because, like lots of us, she is working from home, but she's still working. and so we are, we try to be well vested with this. And so our plan tonight is to start out with Dr. Johnson, because when we see patients in the office that want a pregnancy, the typical scenario is that either he sees a male first, or in many instances, I or one of my partners will see a woman who wishes to get pregnant, and her partner has CF and needs to have a sperm retrieval process. So we see them, we educate them, and then we basically, the care goes to urology. So Dr. Johnson is the one that's actually involved with these couples from a treatment standpoint first. And so he will talk first. And secondly, Marisa will talk about genetics issues tied to cystic fibrosis, which are very important. And then lastly, I will talk about in vitro fertilization, because the sperm that Dr. Johnson obtains can only be used in the setting of in vitro fertilization. I think if people are learning about what it takes, they need to understand that process. So with that brief introduction, Dane, if you can take over and educate us about the relevant aspects.
Yeah, perfect. Thank you for the introduction. Really, really graceful. So I'm going to share my screen because I've produced a small slideshow for people to see that's going to kind of cover all of the important details that I'm hoping to convey to the audience tonight. Are you guys able to see my slides? Can I proceed?
Yes.
Great. Okay. So I thought I would talk first about infertility just as a general description of what we're even describing, and how men with cystic fibrosis kind of fit into the scenario of infertility. I think it's important to kind of define exactly what we're describing when we're saying infertility, which is the inability to achieve a pregnancy after 12 months of attempting or unprotected sex. If you look at the general population, it represents probably about 10% of all couples who are trying to get pregnant may experience infertility. And that rate does increase as the couples age. Fertility is related to the age of the couple trying to achieve pregnancy. Unfortunately, almost all males with cystic fibrosis experience infertility. And I'll go into detail about exactly why this happens, but it has to do with the malformation of the vas deferens. The vas deferens is a structure that brings sperm from the testicle and into the ejaculate, and when it's malformed in men with cystic fibrosis, they essentially have 0 sperm in their ejaculate. Not every single person with cystic fibrosis experiences infertility. The vast majority do. However, the minority of men who still have sperm in their ejaculate are known to have a relatively uncommon mutation of the cystic fibrosis gene. So for the vast majority of men, as you can see here, it represents about 95 to 99% of men with clinically diagnosed cystic fibrosis. We have a problem of the absence of the vas deferens. And so the vas deferens on each side would be malformed and not capable of carrying sperm into the ejaculate. So the ejaculate would have 0 sperm and therefore lead to issues where you're not able to achieve a pregnancy through a spontaneous attempt. I will go into detail about exactly what structures are affected, but essentially it's the structures of the genital tract that are sensitive to the gene mutation, the gene dysfunction from cystic fibrosis. So this can present in men with mild cystic fibrosis, can also be present in men with otherwise asymptomatic gene mutations of the cystic fibrosis gene. So here's a brief layout of the testicular anatomy. This is important to describe exactly where we're having trouble when we're not able to see sperm in the ejaculate for cystic fibrosis. The testicle is the organ that produces sperm, and as you can kind of see on the inside, it's actually composed of many, many, many little tubules inside the testicle, where those sperm are produced from gonadal stem cells that eventually lead to immature sperm. Those immature sperm, which are the sperm that have heads and tails that you can picture under a microscope, are led to the epididymis, the structure directly above the testicle, where sperm are learn to swim and are otherwise matured so that they're capable of achieving pregnancy when they interact with an egg. The vas deferens is essentially the storage unit for sperm, and that is what is evacuated during ejaculation. And that is the key problem when it comes to infertility with cystic fibrosis. So men who have cystic fibrosis or the CF gene mutation, the testicle itself develops normally. So there's sperm gonadal stem cells producing immature sperm. Problem is the sperm have nowhere to go. The epididymis, which is the structure that leads to the vas deferens, and the vas deferens can both abnormally develop in men with cystic fibrosis. And we believe it's because of the chloride ion pump that's responsible for pumping chloride ions from one side of a lumen to the other is dysfunctional in cystic fibrosis mutation. And that leads to an excess amount of mucus inside the vas deferens during development of the fetus in the uterus. This leads to a mucus clog or plug, and the vas deferens itself will actually deteriorate and disappear many times. This actually can occur in the vas deferens, it can occur in the epididymis, it could even occur higher up, closer to the prostate, in structures called seminal vesicles. So these men are born without the vas deferens, and typically also a significant portion of the epididymis is also missing. And essentially, they're born as if they had a vasectomy at birth. So what is my evaluation for somebody coming to my clinic with concerns about infertility? Well, the first test is the easiest test. It's a semen analysis where we evaluate the ejaculate for sperm. If we see 0 sperm in the ejaculation, we would then look for an explanation. One of those investigations involve hormones. Hormones typically are not an issue when it comes to cystic fibrosis and infertility, but it's one of the routine tests that I get when I evaluate somebody with 0 sperm in the ejaculate. Important part of this exam is part of the evaluation is the examination, where I will evaluate the scrotum for presence or absence of the vas deferens. If somebody has a known diagnosis of cystic fibrosis and they have no sperm in their ejaculate and they have no vas deferens, we're talking about this condition of bilateral absence of the vas deferens. We have sufficiently investigated, and we at this point know why there's no sperm, so we can move on to treatment. However, some men may still have some deficient vas deferens, something that you can feel in the scrotum that may still be present, may even be patent, but there's some issue along the genital tract that keeps sperm from getting back into the ejaculate. And so many times it could be a loss of the seminal vesicle. And that's a storage unit closer to the prostate that evacuates during ejaculation. That could also be abnormal. So if somebody has a normal vas deferens on exam but no sperm in the ejaculate, I often get an ultrasound of the testicle as well as an ultrasound potentially of the prostate looking for the seminal vesicle. So once that confirms that we have a disruption of the normal and anatomical genital tract, we move on to talking about treatments. Okay, the treatment for this condition, for the absence of the vas deferens, involves direct retrieval of sperm from the testicle. As I mentioned earlier, the testicular anatomy and testicular function actually progress normally in men with cystic fibrosis. So it's rare that I come across men with low testosterone in addition to this problem. They also have normal sperm creation and production inside the testicle, just with a difficulty achieving a sperm in the ejaculate. So what I do is a clinic-based procedure for these men where I can retrieve sperm directly from the testicle where those sperm are being created. So the procedure is in clinic. I numb the testicle as well as the scrotal skin itself. After numbing, it takes about 30 seconds. The numbing medicine works for about 4 to 6 hours. The numbing medicine works well in the vast majority of people that we use less than 10 milliliters of numbing medicine. That's a very small volume. Once you're numb, I'm able to then proceed with the biopsy by using a small needle that I insert into the testicle through the scrotal skin and retrieve sperm directly from the testicle. Now, if somebody has a large dilated epididymis as part of their obstruction, I could potentially even aim my needle there to try and draw some mature sperm out. But many times, men have sperm that are really only successfully retrieved from the testicle. So once I put the needle in, I apply a negative pressure to the needle, and I am actually able to pull some of these very small tubules that contain sperm into my needle. We can then evacuate the needle into a petri dish. We can then use that in our andrology lab at Washington University where we process the tissue. We can identify sperm, isolate them, and then cryopreserve them with a very high success rate for this condition. And that's because, as I mentioned, the issue is an issue of sperm getting out, not sperm being produced. So there's millions and millions of sperm actively being produced in many men all day, every day, and it's just a matter of getting to the sperm and getting them out. So here's a brief illustration of the procedure itself after the testicle is well numbed. That's kind of a description of the mechanism that I use to achieve that negative pressure to pull on the needle. With success rates almost 100%, with the variability of saying we can't guarantee 100% ever in medicine, and there can be rare circumstances where there's an issue of sperm production, but we would see evidence of that on our workup with our hormone evaluation. Recovery period is fairly quick. Most people recover within 24 hours. They'll have some soreness because of the procedure and numbing medicine. Tylenol, ibuprofen are usually sufficient. And then in addition, it's a safe procedure. It's something that we can do at our fertility clinic with just numbing medicine. There's rare risk of infection, rare risk of bleeding. The vast majority of people feel a little soreness for about 24 hours and can get back to their life and their work without really any inconveniences beyond that. One thing to kind of mention before I pass on is that the sperm that we retrieve from the testicle or the epididymis are typically immature. They are not yet matured to the point of becoming mobile enough to reach an egg and fertilize an egg, and they've also not yet developed an active acrosome. And that's the process at the head of the sperm that's important for the sperm's ability to penetrate into an egg and fertilize the egg. So these sperm are not yet capable of fertilizing an egg on their own, and that's why we warrant in vitro fertilization when we retrieve sperm from the testicle. One question that sometimes is asked is, what do we do with the sperm that day? And the vast majority of people who have procedures for sperm retrieval have their sperm cryopreserved. And there's two reasons for that. One is there's no difference in terms of fertilization rates or pregnancy rates, whether we freeze the sperm for later use or try to use that sperm that day for in vitro fertilization. It eliminates potential complications where we try to retrieve sperm and are unsuccessful. And therefore, this kind of ensures the ability to proceed with in vitro fertilization, knowing we've already got sperm and we've banked that sperm for future use. So that's what we typically proceed with, except for extremely unusual circumstances. All right, so that was my presentation on the male aspect of infertility. I'm going to go ahead and pass the microphone on so we can hear a little bit about what to do once we retrieve the sperm, the importance of genetic testing.
Thank you. Can you hear me okay?
Yes, we can.
Okay, wonderful. So as Dr. Odem said, my name is Marisa Andrews. I am a certified genetic counselor within the clinic, and I've been in the field for about 12 years, but about 2 years in this particular role. And so today I'm going to talk a little bit about genetic testing related to cystic fibrosis, and also the reproductive options that are available for couples who have a chance to have a child with cystic fibrosis. And before I jump in, I just want to say that I do recognize that this can be a really sensitive topic for some folks. I know people feel very strongly sometimes about whether or not they themselves would be interested in doing genetic testing of embryos or of a pregnancy for something like cystic fibrosis, especially when they know and love people who have this condition. So I just want to stress before I start that my role as a genetic counselor and our role as a clinic is really just to let you know what all of your options are and give you information so that you can make the choice that's best for you. We're not here to advocate that couples do one thing over the other. So to start off with, I just wanted to talk a little bit about genetic testing for cystic fibrosis itself, because we have increasingly learned over time that it is a really complicated topic. The gene for cystic fibrosis and all the variations that can occur in that gene are a lot more complex than we initially appreciated. So there are really 3 different types of ways that people get genetic testing for cystic fibrosis. One that I'm really going to focus most strongly on today is what's called genetic carrier screening. So as its name implies, this testing is really designed to tell people whether or not they might be an asymptomatic carrier for cystic fibrosis for the purposes of knowing the chances of them having an affected child. We do have professional guidelines from the American College of Obstetricians and Gynecologists, as well as other organizations, that tell us that we as providers should be offering this testing to all patients who are pregnant or are planning a pregnancy. I stress that it should be offered. It is still optional testing, so it's not something that patients or couples need to undertake, but it's something that we should be talking about with our patients so that they are aware of that option and can do the testing if they want. Cystic fibrosis is also, of course, tested for through newborn screening. All 50 states in the United States do have cystic fibrosis on their newborn screening panels. Typically, newborn screening for cystic fibrosis actually starts with biochemical testing, not genetic testing. But genetic testing is often a second tier if the biochemical testing is abnormal, to try to confirm exactly what's going on there with that baby. And then finally, there's diagnostic testing. This is testing that can be done for infants through adults. And it's the type of testing that's done when a person is suspected to have the condition due to symptoms that they are presenting with. So this testing is meant to confirm that a person has cystic fibrosis or to reduce the likelihood that that's the answer for their symptoms. Really importantly, no matter which of these types of genetic testing that you're talking about, there are a few different ways that the gene can be investigated or tested. And all forms of genetic testing are not created equal, which I'm going to talk about next. But before I move on to that, I just want to stop and talk a little bit further about genetic carrier screening, since again, that's the type of testing that our office is most often involved in ordering. So as I mentioned, we do offer this testing to all of our patients, since people are coming to us often desiring a pregnancy. But it's especially important for us to talk about if one of the people in the couple or the patient either has cystic fibrosis themselves or a family history of cystic fibrosis. So genetic carrier screening is, again, a DNA test that's meant to determine if a person or a couple has an increased risk to have a child with certain genetic conditions. Usually this type of testing focuses on conditions that are either autosomal recessive, like cystic fibrosis is, or X-linked recessive. The reason that this testing focuses on those types of conditions is because these are things that people can be carriers for without showing any symptoms themselves, and they also typically do not have a family history of that disease if they're only a carrier for the condition. So these are things that we can really only know about by doing DNA testing. There are lots of different laboratories in the United States that offer genetic carrier screening, and they really vary a lot in terms of which conditions are tested for and how many total. Some screen for only a small handful, others screen for hundreds. But cystic fibrosis is pretty consistently on all of the panels because, again, it is recommended in professional guidelines for everybody. Just as important as what genetic carrier screening is what it is not. So genetic testing is almost never perfect, and that's true of genetic carrier screening as well. So genetic carrier screening can never completely rule out that a person is a carrier for a genetic disease like cystic fibrosis. If your testing is normal, it reduces the chances that you're a carrier quite greatly, but it doesn't bring your risk to zero. It's also not a comprehensive screen for all genetic conditions. There is no version of this testing that looks for all genetic diseases. And it most certainly cannot guarantee the health of an individual's future children. Unfortunately, no test can do that for us. So when we're talking about genetic testing, including genetic carrier screening, there's 3 different types of tests that can be done for the gene for cystic fibrosis. And to illustrate the difference between these different types of testing, what I've done here is basically made a simplified version of what the cystic fibrosis gene looks like, which is not accurate, of course, to what it looks like at all. But a gene is really just a sequence of DNA letters. And so here at the top, I have indicated that the cystic fibrosis gene is supposed to look like A to Z in alphabetical order. And so when we're doing genetic testing, you can think of that essentially as just doing a spell check for the gene, where we're looking to see if the correct and expected sequence of the gene is there, or if one of the letters is replaced with something that we didn't expect to be there. That would be what we call a variant, or what used to be called a mutation. So the first type of genetic testing that you'll see somewhat frequently for cystic fibrosis is what's called genotyping. And what genotyping means is that the laboratory has picked out a certain number of variants that are relatively common in cystic fibrosis, and those are the variants that they're going to look for. So here you can see I've listed genotyping in this example as a lab that's going to look at 4 particular spots in the gene labeled in red, where the letter that we expect to be there has been replaced by a different letter. That's the variants that they're going to look for. So if those variants are present, your testing is going to come back positive. But if you are a carrier or affected with cystic fibrosis because you have a variant that's in one of the blue letters, genotyping is going to come back normal for you because that is not a place that the laboratory is going to look. So that is not a result that they would be able to report out. So genotyping basically is a less comprehensive form of genetic testing compared to full gene sequencing, which, as its name implies, means that the laboratory is looking through the entire sequence of the gene from start to finish. So here you can see that this person's gene sequencing was normal, but they have investigated every letter of the gene. Genotyping, as I'll talk about in a second, tends to be better for certain groups of people than others, usually based on ethnicity, and I'll talk in a moment about why that is. And then finally, sometimes whether labs are doing genotyping or full gene sequencing, sometimes they will additionally do something called deletion duplication analysis. What this means is that most variants in a gene are essentially one letter swapped out for another, and genotyping and sequencing are very good at picking up those types of genetic changes. But deletions or duplications are another type of genetic change that can cause disease, where either a chunk of the gene is missing or is duplicated, as I've shown there in the last example. Sequencing and genotyping are not good at picking up deletions and duplications of certain sizes, and so that's an analysis that has to be done separately. So here's an example from a laboratory that does direct-to-consumer testing. I specifically wanted to talk about this because I know that doing genetic testing from home is becoming really, really popular. So this is an example from a laboratory where you can order a kit online or pick it up at your local pharmacy without the involvement of a physician or a genetic counselor. And this is an example of a pretend patient's test report where they have done carrier testing for cystic fibrosis, and this person's results have come back normal, meaning they did not detect any variations in the CF gene. This company, like a lot of direct-to-consumer companies, does genotyping. So you'll see here that they mention that they tested for 29 variants in the cystic fibrosis gene. And they also mention that this testing is most helpful in people who have Ashkenazi Jewish, European, or Hispanic ancestry. That's because these 29 variants account for a large percentage of the mutations in those populations, but they don't account for as large of a percentage of the mutations in other populations, like people who have Asian or African American ancestry. So while this test is not, useless in couples and or people who have other ancestries, it certainly isn't going to provide the same level of risk reduction that it will for people who are in these ancestries that are listed. But even if you are in one of the preferred ancestries, again, this genetic testing coming back normal does not reduce your carrier risk to 0. You can compare that with the type of testing that we do in the clinic. So this is genetic carrier screening from a laboratory that does full gene sequencing. And what they're showing here is how well their testing performs for cystic fibrosis. So what you can see in the table is they list several different ethnicities, along with how likely it is that people from those ethnicities are carriers for cystic fibrosis. So 1 in 25 Caucasians, 1 in 61 African Americans, and so on and so forth. The next thing that they show is the detection rate, or how well their test performs on these different ethnicities. And what you'll notice there is that the testing does still have different performance levels in different ethnicities. And the reason for that is, unfortunately, we have a lot of genetic information and data from studies that have been done a lot of times in the Netherlands and other Scandinavian countries where the population is Caucasian, and we have less data about variation in other populations. So the testing performs really well in people who are Caucasian or Ashkenazi Jewish, but not as well in people, for instance, who are Asian. And then the final to last column down there shows you what are the risks that a person is a carrier if their testing comes back normal. So we call that their residual risk, which essentially is the chance that the test gave you a false negative. So again, you can see if you're Caucasian, that statistically there was a 1 in 25 chance you were a carrier before testing. After you test and it comes back normal, that reduces your risk down to 1 in 401, which is certainly very low, but not 0. So the next thing that comes up for us as a challenge once we've done genetic testing is understanding those genetic test results. And there's a few things about cystic fibrosis gene results that are kind of difficult for providers and for patients alike. So number one is that we've learned over time that variants in the gene for cystic fibrosis really can cause a very wide spectrum of symptoms. So there certainly are plenty of mutations that cause pancreatic insufficient CF or classic CF, but we know that very different combinations of variants in this gene can also cause things like CFTR-related disorders, which would include things like men who have infertility due to absence of the vas deferens with really no other symptoms of cystic fibrosis present. The second thing about cystic fibrosis that has kind of surprised us over time is that traditionally we think of recessive diseases as being things where carriers are completely asymptomatic, they have no symptoms or health issues at all. But we've learned that that's really not the case for people who are carriers for cystic fibrosis. So while most people who are carriers for CF are healthy, we know that carriers are at increased risk for certain types of health conditions compared to people who are not carriers. So for instance, men who are carriers for CF have about a 7% rate of infertility. That's compared to just 1.6% of men who are not carriers for cystic fibrosis. And then finally, the last challenging thing about CF test results is that a person's genetic test results really cannot always predict for us how they're going to be affected. So which of those categories at the top they're going to fall into. And this is especially challenging for couples who are coming to me because they're both carriers for cystic fibrosis. Sometimes there might be information that's very clear-cut about what type of symptoms or what type of severity we would expect in their children from the combination of their two mutations, but other times we can't provide them with that type of prediction, and that's a really challenging position to be in. So this is just a very quick slide. I was just going to finish up by talking about reproductive options. So these are the two types of scenarios I would most often be seeing to talk about reproductive options. Either a scenario where both partners are carriers for CF, in which case they have a 25% chance to have an affected child with each pregnancy, or couples in which one parent is affected with CF and the other is a carrier, in which case they would have a 50% chance to have an affected child with each pregnancy. So the reproductive options for couples such as those depend on when in their journey that they're coming to us. So for our particular clinic, we're almost always seeing patients prior to them conceiving a pregnancy. So one of the options that we would talk about most frequently would be in vitro fertilization, which Dr. Odem is going to go through, with something called pre-implantation genetic testing, or PGT. So very briefly, once a couple goes through an IVF cycle, the woman would have her eggs retrieved and the man's sperm would be used to fertilize the eggs. then at that point, if a couple is interested in doing genetic testing for something like cystic fibrosis in their embryos, we would basically allow those embryos to develop for about 5 days after fertilization, at which point we would remove a very small number of cells from each embryo that we would send off for genetic testing, while the embryo itself is actually frozen and remains in our laboratory for future use. Those cells that we send off for genetic testing are going to be checked for genetic markers that will help us tell the difference between embryos that are affected with cystic fibrosis, those that are carriers, and those that are predicted to be unaffected and not carriers either. When those results come back, that information can be used by the patients and the doctors to select which embryos to transfer to the woman's uterus. There are, of course, other options beyond IVF with PGT. So again, if you're coming to us prior to pregnancy, it would also be an option to use donor eggs or sperm from a donor that has tested negative for cystic fibrosis. It's also possible to use donated embryos to become pregnant or to pursue traditional adoption. If a couple is not interested in any of those options or is already pregnant, it's also possible to do genetic testing for cystic fibrosis during a pregnancy, either in the first trimester using a procedure called CVS, or in the second trimester using something called amniocentesis. And then, of course, couples may not want to do any of those things, in which case a child could also be tested after they're born, either through newborn screening or other additional testing if needed. And with that, I'll go ahead and hand it over to Dr. Odem to talk about the IVF process. Thank you so much.
Thank you, Marisa. It was very nice. Let me just share my screen here if I can get it up. I see Dr. Johnson. Okay, can everybody see this and hear me? Yes?
I am only seeing you. I'm not seeing your screen.
You're not.
Dr. Odem, do you see the share screen button at the top in the middle next to the
Let me
microphone?
escape. I clicked that first, but then maybe I unclicked it in the process. I did share screen.
And then I had to click Keynote on mine. I don't know if yours is also.
Did you have to, it says click here to start sharing this screen?
Oh,
And
there you
that-
go.
There we go.
Did that do it?
Yep.
Yes.
If you want to hit presentation mode, we're ready.
Yeah, okay, good. So thank you to both. I must say one of the highlights of my job is that I get to work with absolutely wonderful people. And I remember caring for cystic fibrosis patients before we had somebody in urology with the credentials and talents of Dr. Johnson, and before we had a genetics counselor on board. And, you know, it is better with them, and I am thankful for that every day. So I appreciate your presentations. So I'm going to just try and go through in vitro fertilization and touch on, I don't know if you can see my mouse, but I'm going to talk about the stimulation that patients have to go through in preparation, then talk a little bit about egg retrieval. How do we get the oocytes or eggs in the lab? And then I'll talk about what happens with those eggs and sperm leading up to an embryo transfer. And then there are some other issues that I might dwell on briefly. So an IVF cycle starts with stimulation. Now, I must say before patients begin the stimulation phase, there is a lot of preparation. There's a lot involved. It's a big decision because patients doing in vitro fertilization are going to be administering a lot of injectable medications either to themselves or their partner. And so there's a lot of prep, and there are also some screens that we need to do before they start because we don't want to start the cycle if there are obvious impediments to our success. So, you know, preparation and being organized in advance is invaluable to the ultimate outcome. So I put this very hard to read slide on here, not to go through details, but to just kind of give a pictorial visit of one of the protocols that we use. And our protocols are named by the medications, and my mouse doesn't seem to want to point here. There it is. But this particular protocol is the most common protocol. And if you look at the timeline at the bottom, you'll see that this process takes almost 2 months. However, the first month in this protocol, the woman is taking typically oral contraceptive pills for about 3 weeks, and then she starts the first medication when she is almost done with the pills, and that medication is geared to kind of shut the stimulation that normally exists from the brain to the ovary down. And then in the second half of this is when all the shots start, and typically patients will be on a shot to prevent ovulation, a shot of FSH, which will stimulate her follicles to grow, and a shot of a different medication that's FSH and LH. And the goal is to stimulate the ovary in a fashion that will be safe so that we'll get an adequate response, but not do an overzealous response. We don't want people to suffer from this process. The goal is to lead up until they get the final injection, which is typically pregnancy hormone, which causes the eggs to genetically mature. So this is just one brief picture of what we're doing. So, women are getting these shots in their lower abdomen, and they're getting ultrasounds, and you can see this is like a vaginal probe. So here is an ovary, and all of these little black circles are these structures called follicles or cysts within the ovary that are going to develop as a result of the medications. Ultimately, we're leading up to an egg retrieval, and this image over here is actually, this is a transvaginal image. You can see the ovary I'm circling with my mouse. It's adjacent to the uterus, which is over here, and all of these black circles are follicles. And this little white line here is the needle that has gone through the vagina into the ovary, and this tip right there by my mouse arrow is the end of that needle. And so that's how we get these. We go through the vagina into the ovary and drain the fluid from these cysts. And this is done obviously while the patient is asleep. So we have anesthesiologists that come to our unit and give patients, medications that make them not only comfortable, but of course it's very important that patients are comfortable and asleep so that they're not moving, since we have this long needle inside their ovary. These may look scary, and I guess they are, but for people like those of us that do this, we've been doing this for years and years. Now, this is an old cartoon picture that I don't find to be that accurate, to be honest, but it portrays the image. So in the top, it's kind of another picture similar to what I just showed you, where the needle is coming in. You can see a vaginal ultrasound probe that's going behind the uterus, looking at the ovary and sticking the needle. I'm stealing this artistic work, but I always am kind of humored by whoever drew a very small ovary, not one that's stimulated. So I'm not sure they were fully in the game when they drew the picture. So after we get the follicular fluid, it's passed off in test tubes, which are literally the only test tubes that are used in the whole process pretty much, even though people call it a test tube baby. And this is one of our embryologists looking through this little incubator. So all the work is done inside these incubators, where the gas concentrations and temperatures are controlled. And you can see in this top right picture, there's an egg here surrounded by cells. And what they're doing is looking at the follicular fluid and selecting out the eggs to find them. Then what happens later that day, and this is a picture from our lab, they're going to do intracytoplasmic sperm injection, which is what Dr. Johnson referred to when he was talking about you may have sperm that have not developed an acrosome. So intracytoplasmic sperm injection, where an individual sperm is drawn up and literally injected into the egg, is what intracytoplasmic sperm injection refers to. And this is something that's done for immature or sperm that's testicular sperm is going to be used like this, or in couples where the sperm counts are very low. If we do IVF and we have very significant sperm issues without intracytoplasmic sperm injection, or ICSI as it is known, the fertilization rates are going to be very poor. With intracytoplasmic sperm injection, we hope to have fertilization rates of about 70%, which is what you expect to get doing conventional IVF when the sperm is normal. You can see on this top slide here, this needle is being used to pick up a single sperm, and it's very important that only one sperm is injected, and there's details of how that's assured that I won't go into, but on the bottom you can see this is what's called a holding pipette, which using this table here that they're doing, it uses things called micromanipulators, so you can see they're turning the dials on these things. So this stuff is very, very small. So to pick up one sperm and carefully put the needle into the egg perpendicular to the axis, this is a polar body up here, so that means the egg is genetically mature and they're injecting the sperm into that. So after they do that, the injected eggs are going to be put into a shelf, and these are incubators that will meet the needs for 4 patients at a time. So you can see top, next. And so all of the dishes containing the injected eggs or embryos are going to be in this incubator, which has, as you can see, your controlled parameters. The day after intracytoplasmic sperm injection is performed, at about 16 hours, the embryologists are going to check the oocytes, and they're going to be looking for these 2 circles on the inside. These are called pronuclei, and it's crucial to observe these oocytes within the right time window, because these 2 pronuclei will fuse and form one nucleus. So you want to see it at this point where you can say, here is the nuclei from the egg, and here's the nuclei from the sperm, or vice versa. You, of course, can't tell which. And then also when this happens, I'm sorry, I'm struggling with my mouse, the egg has to cast off a second polar body. So this is in the process of you reach back to biology class in junior high, high school, I don't know. This was all something that everybody had to sit in class and learn about. And it was good that we learned about it because we use it every day. So this is a normal fertilized egg. You probably in biology learned it as a zygote. A synonym of a zygote is a 2PN, which stands for 2 pronuclei. So then, once we know how many eggs are fertilized, these are left, and this is stolen from the same graph that Marisa showed. Here's what we just looked at in the top left, and then this fertilized egg will then divide. The term we use is cleave. Here it's cleaved to a 2-cell structure, which would happen typically 2 days after the egg is retrieved. On day 2, it'll be 2 to 4 cells. On here it's a 4-cell. Here's a day 3 embryo where there is more, and then it collapses and it forms this kind of globular structure called the morula, and by day 5 it forms ideally a blastocyst, and that's what this is. You can see this mass right here is an inner cell mass, which becomes the baby, and the other cells here are called trophoectoderm. And as Marisa talked about, in cases where people are biopsying embryos to see what's there genetically, those biopsies are done at that cell stage with current technology. Most people that are doing in vitro fertilization, where the male has cystic fibrosis and we're using the sperm that Dr. Johnson has collected, assuming that the woman does not have a CF mutation, we typically would not need to do genetic testing in that instance, so we would move on to an embryo transfer in the same cycle. So embryo transfers are done. This slide tries to show the whole thing. So here's an embryo. This is actually a cleavage embryo, but you can see in the lab they're going to aspirate the embryo into this catheter. That's what they're trying to show here. And then using ultrasound to look at the uterus, the catheter is placed up into the uterus about 15 millimeters or a centimeter and a half from the top. And you can see the ultrasound image here with the catheter in the uterus. And so we put this up here, and once you know it's at the right place, you just kind of push the plunger, and the volume of air in embryo is very small. So you cannot see the embryo go into the uterus, but you can see the air that surrounds the embryo. And then the catheter, of course, is checked afterwards to make sure that the embryo didn't stick to the catheter. So that's the process. I've included some statistics here because people want to know how well this works. Statistics in IVF are, sometimes something you need to read the fine print. We have our fine print down here. So I have 3 stat slides. I don't think I need to go through all of them. But when we see new patients in the office, they always want to know, what are my chances? And these are 2018 live birth for new patients. So in other words, in all the patients that went through an IVF cycle in our program in 2018, and if we just look at their very first cycle, so the very first cycle in which they had a retrieval and they had an embryo transfer. So this doesn't include people that were like making embryos and doing genetic testing and doing embryos later. This is just straight IVF. If we look at the less than 35 group, you'll see that there were 162 patients, and of those, 112 did IVF once and had a delivery of a live baby, so which was usually one baby. You can see it was one baby 87% of the time. It was twins 11.5%, and triplets 2%. This is higher than we would like, but we usually will put one embryo in for a transfer, but sometimes 2. And anytime we put one embryo in, we have a 3% chance of that embryo splitting. So you can see it's good to be young when you do IVF. As you get older, it does not work as well. This looks like 41 to 42 being a 33% rate is better than 38 to 40, but obviously that's what happens when you have small numbers. But when you get to be over 42, the 43 to 44 typically has success rates of about 5%. So these rates look wonderful. If you look at more patients involved, so this is everybody that did a fresh IVF cycle in our program. So it's not just the 162, I think we said before. So there's another 60 people that are a combination of people that were doing maybe their second cycle or their third cycle or their fourth cycle. And not that many people do that many. But if you look at subsequent cycles and pool them, then you will see that the overall pregnancy rate is not as high. But still respectable, especially for, the mindset that I sometimes compare is when I first started doing IVF, about 1 in 25 patients got pregnant. So it's improved. People ask about frozen embryo transfers because we do freeze excess embryos and use them. And traditionally that works close to the same. This is all patients, not their first FET. And if you compare these numbers to the prior slide, you'll see that it's pretty well. And the way we report our frozen embryo transfers is by the age the patient was when she froze her embryo. So this 1/2 over here literally means that somebody that was 43 or 44 had embryos frozen and used them and got pregnant. And that person I would contend is lucky. That's not a very likely thing. So that is my soiree of IVF, so to speak. Thank you very much. and I will turn it over to our host if we have questions. So,
Thank
and I
you
have one,
all.
and I actually have one
Excellent.
question. Yeah, I have one
Yes.
question that I would ask Marisa if there aren't enough. So,
Okay, well, I want to thank you all. We'll get into questions, definitely. Thank you all very much for your time and expertise. It was very informative. Now, before we open it up to Q&A, I would like to introduce someone who has firsthand experience with these procedures, and he would like to share a bit of his personal story with all of us. Jeremy?
Yeah, hello. My name is Jeremy Parks. I'm 36 now with CF. And I'm seen at the WashU clinic for my CF care with Dr. Rosenbluth. And my wife and I did in vitro at WashU, in the WashU clinic. It was actually with Dr. Emily Youngheim, was who we went with. Back in 2012, we did a breast transfer. And so I had to have a testing procedure, which was one of my questions. But and we did. They actually put 2 embryos in, and they both took, and we had twins in 2013. We had 1 embryo that we were able to freeze. We did that one, a frozen transfer in 2015, and that worked as well. So 3 little ones, courtesy of the WashU Fertility Clinic. So can't say no great things about the work you guys do. That was a great experience. It went really, really smoothly. That's one thing Dr. Youngheim kept telling us was how smoothly it seemed like the whole thing went. I don't know if everyone has that same experience. I'm sure not everyone's is quite as perfect as ours was, but it really was great. And everyone at the clinic was exceptional to work with. We did go through genetic counseling. I think it was mandatory at the time. We had to at least sit and speak with a genetic counselor, and we did have my wife tested to see if she was a carrier. I don't remember exactly which. There were several different tests that we were told we could have her tested for, and we did one that I want to say it tested for 500 different mutations somewhere in there, and it came back negative. So they are my and her biologic children. So yeah, it was really quite a great experience.
Great.
I
Thank you
have,
so much, Jeremy. Oh,
yeah, I don't know if it's possible to share my screen. I like to
you sure
share a
can.
picture.
Yeah, there's at the very top, right next to the audio and video, there's a screen image. See that at the top?
I see that. Okay. Is it showing?
Yes.
Aha, so there's my
oh
three.
man, bravo.
So obviously the brunette and the blonde are the twins. And then we had our third one was a little redhead, so we had one of each.
That's crazy.
Pretty cool.
Great photo.
I guess we
Yeah.
don't have to ask you what you do spending your time now.
No, that's where my time goes. And there's the whole family. This is a picture is a couple years old, so they're